Hi everybody, this is Mrs. McDaniels, and today we're going to do a quick overview about heart failure. And big thing you need to understand is the difference between systolic and diastolic heart failure, but also understand too that the compensatory mechanisms that the body and the heart attempt to do to increase blood flow in the body ends up being counterproductive in the long run. And as a nurse, big thing that you're going to be doing with patients is going to be a lot about symptom management, but also trying to help the body meet the demand of its nutrients and oxygen that it requires to function, but also trying to take some of the workload off the heart. So it was formerly known as congestive heart failure simply because of the pulmonary or peripheral congestion. About 6 million adults in the United States have heart failure. About half of those will pass away within 5 years of their diagnosis. Heart failure is very costly in the United States, an estimated $30.7 billion each year, and this includes the cost of healthcare services, medications to treat heart failure, and the missed days of work. Here are some interesting facts that came out recently from the CDC. This is looking at the heart failure death rates between 2014 and 2016. If you want to look more at this and some of the data, the CDC has a lot of great information. This is a really good video. It may pop up at some point through Khan Academy. It's about 9 minutes long. It will go a little bit into the patho. I really think it would be a good one for you to watch, just to kind of refresh your memory and go in a little bit more detail. So basically, heart failure occurs when the heart is not able to perform its task by pumping blood efficiently throughout the body, resulting in the inability to meet the demands of the body for oxygen and nutrients. A lot of times it's indicative of a myocardial disease in which there's a problem with the contraction of the heart, so it'd be a systolic dysfunction, because that's when the heart is actually beating, or filling of the heart, which is a diastolic dysfunction, and that's when the heart's at rest. This is some good pictures here. Take a look. This is showing normal when blood is actually filling. This is when the heart's at rest. It's filling up with both on the right side the unoxygenated blood and on the left side the oxygenated blood. You'll see during systole when it's actually pumping, you can see how it squeezes here, and typically the ventricles will pump out about 60% of the blood. When there's a systolic dysfunction, this is actually when the heart is trying to beat, trying to push blood out of the heart. Enlarged ventricles make it very difficult for the heart to pump out all the blood that has filled into it. So typically this is where a lot of problems begin, because the heart will kind of have this demand that it does need more blood, and so the heart's going to respond appropriately, but it's not sustainable. When there's a diastolic dysfunction, this is going to happen sometimes when the ventricles are stiff. It has an inability to dilate enough in order to allow the blood to come in. Ventricles also have a difficult, can at times get out of the, can pump out the amount of blood coming in, but not a, how can I say this? There can be a diastolic dysfunction. The ventricles can still push out the blood, but the amount coming in is much less. So still there's going to be a reduced amount of volume. I hope that makes sense. So systolic versus diastolic. Systolic is usually characterized by weakened heart muscles. Diastolic, as I mentioned before, usually is stiff and non-compliant heart muscles. Remember, the ejection fraction is the percent of volume at the end of diastolic of blood that's ejected with each contraction during the systolic, and that will help determine the type of heart failure. Your normal EF is going to be greater than 55%. And sometimes the amount of blood can be normal during the diastolic, but can be severely reduced during a systolic dysfunction or heart failure. So how's the body going to try to compensate? So the body compensates in a couple ways. The nervous system will send a message to release catecholamines to cause vasoconstriction and increase heart rate. The endocrine system, the RAS system, will be engaged to also cause vasoconstriction and sodium and water retention. It's going to want to hold on to these things because it wants to create a greater pressure within the body. Heart compensation, especially when there's a low stroke volume, can happen with the adrenal glands to release norepinephrine and adrenaline. That will increase the heart rate. Increased heart rate over time, unfortunately, can weaken the muscles. Also, it's counterproductive because it allows less time for the ventricles to fill up with blood after each heartbeat. Also can cause dilated ventricles, which leads to hypertrophy, and that increases the heart demand for oxygen and nutrients as well, which will end up affecting diastolic function by impairing the heart's ability to actually relax properly. So over time, what ends up happening is through these compensatory mechanisms, they cannot be sustained, and so what ends up happening is a decompensation. So you'll end up having congestion, which is a backup of blood into the lungs and other organs, and it will present itself through shortness of breath and edema. Or there can be a low output, which is decreased cardiac output. There will be reduced blood flow to the brain and vital organs, and it will present itself in symptoms of lightheadedness, fatigue, decreased urine output, and organ damage, specifically the kidneys. So some heart failure risk factors, the ones in red, I would really focus on. The major ones, history of hypertension greater than 65, male, person may have already had an MI, they have left ventricular hypertrophy, vascular heart disease, and obesity. Some of the minor risk factors, but are still important: excessive alcohol consumption, smoking, dyslipidemia, diabetes, toxins, sleep disorder, breathing like obstructive sleep apnea, chronic kidney disease, low economic status, psychological stress, sedentary lifestyle, and genetics. So make sure you know all in red at least. So here are some of the causes of heart failure, and here's a good way to remember it. Failure, fatty heart valves, arrhythmias, infarction, lineage, which is basically genetics, uncontrolled hypertension, recreational drug use, alcohol abuse, and evaders, which is like infection. Right-sided heart failure, this is going to be when there is congestion in the peripheral tissue and viscera from the right ventricular failure. Failure of the right ventricular causes inability of the heart to accommodate for venous blood return. You may see jugular venous distension because of the increase in the venous pressure, and increased venous pressure can also cause an increase in hydrostatic pressure, which basically means that the patient has excessive blood or excessive fluid circulating in the body. So right-sided heart failure, again, is from the right ventricular failure. Left-sided heart failure, you're going to see pulmonary congestion from the impaired left ventricular function. Left ventricular is unable to pump blood into the systemic circulation and aorta effectively. So basically things are getting backed up into the lungs. Pulmonary pressure and pulmonary venous blood volume increase, which forces fluid from the capillaries into tissues and alveoli, which causes pulmonary interstitial edema and impaired gas exchange. So make sure you have a good understanding between right side and left side heart failure. And this will kind of give you a side-by-side in terms of the signs and symptoms you'll see. And the ones in red, make sure you understand. Lab tests and diagnostics, your brain and atrial natrenic peptides usually are going to be elevated with heart failure. Chest x-ray, you'll sometimes see the enlargement of the heart. Troponins are going to be elevated with heart failure. Electrolyte disorders, you'll sometimes see hyponatremia, hypokalemia, and hypomagnesemia. And ABGs, a lot of times these individuals will be in metabolic alkalosis. So from a nurse perspective in managing these patients, what you're going to encourage them is to have routine exercise, start slow, and exercise to what they can tolerate. Encourage a low sodium diet. Fluid restrictions, because again we're looking at how can we decrease the workload of the heart. Refrain from smoking. Make sure they adhere to their medication regimen, and make sure that they do have routine visits and follow-ups with their primary care provider. Nursing care, daily weights. You want to monitor their I's and O's. Oxygen as prescribed, because again, remember, oxygen is a prescription and it is a medication. Keep the patient in high Fowler's position to kind of help with ventilation. Other things, assess for signs of medication toxicity. We'll talk a little bit about that. Encourage bed rest, especially if they're unstable. Energy conservation, so that's going to be, take breaks. We don't want these individuals to be sedentary, but we don't want them also to increase demands of the heart. Maintain dietary restrictions, the DASH diet, low sodium, low fat are going to be important, high fiber, and providing emotional support to these patients. Medications. Make sure you get a complete list of herbal supplements that a patient takes. Some can actually stimulate the cardiovascular symptoms that can actually exacerbate their condition, but also interact with certain medications. So again, you have to make sure you ask questions appropriately. Medications that may be used to treat patients, diuretics that will help reduce the preload. If you give IV furosemide, it can be given by IV push, but the big thing you want to make sure is not to go faster than 20 milligrams per minute. It can actually cause ototoxicity if it is given too quickly. And since that's in red, it's probably a good point to remember. Your ACEs and ARBs and calcium channel blockers, those will help reduce the afterload, digoxin, dopamine, dobutamine. They will improve contractility and improve the overall cardiac output. With digoxin, you're going to make sure you do your education about self-administration, how to check their heart rate, and signs and symptoms for toxicity. And we've talked about that before in other presentations. Beta blockers help to block catecholamines, which catecholamines will increase the heart rate and constriction. And so those are going to be beneficial to kind of counteract how the heart and body try to compensate. Sometimes they may give patients human, the B-type natriuretic peptide, That's typically going to be for acute heart failure, can cause diuresis. It should only be given by IV, and typically this patient will be in the ICU and be monitored. Vasodilators like nitroglycerin will prevent coronary artery vasospasms, help reduce that preload and afterload, and decrease the myocardial oxygen demand. Important education: make sure you teach a patient to weigh themselves at the same time every day in the same type of clothing on the same scale. That's really important because all of us probably have stepped on a scale at different places and get different weights, and different times of day get different weights. They need to be aware that any significant changes in weight, 2 to 3 pounds per day or 5 pounds within a week, they need to let their primary care physician know, so they can adjust the diuretics, or they can adjust diuretics if they have been previously instructed. If you go to page 461, table 5-4 in your Honens, it'll talk a little bit more about treatment modalities. Ultrafiltration, it's a kind of dialysis. It's not used much. Cardiac resynchronization therapy basically is a pacemaker. Defibrillators, that's going to be for your life-threatening arrhythmias. A ventricle access device, this is typically going to be used in end-stage heart failure, kind of as a intermediate step to heart transplant. It will help decrease the workload of the left ventricle, and ultimately, if the heart, quite honestly, is not functioning properly anymore, the individual may be a candidate for heart transplant. So if you ever have patients with heart failure, some of the possible nursing diagnoses that will be applicable to this population: decreased cardiac output, activity intolerance, excess fluid volume, ineffective tissue perfusion, and impaired gas exchange and fatigue. Pulmonary edema. This is usually going to be an abnormal accumulation of fluid in the lungs. This is going to happen at times with patients with left-sided heart failure. Patients may have anxiety, tachycardia, shortness of breath at rest. They also may have crackles and produce a frothy, blood-tinged sputum. Nursing management for these individuals: you want to raise the head of the bed, give them oxygen, BiPAP, ventilation, also to kind of help with the anxiety, IV morphine, that will help decrease some of that rapidness, especially if they're panicking and breathing too much, and loop diuretics to kind of help get rid of that extra fluid that is backing up. Give them medications as prescribed to improve cardiac output, and teach clients a way to improve their tolerance to activity moving forward. Patients, if they do have pulmonary edema, associated nursing diagnoses that might apply to this population: impaired gas exchange, ineffective tissue perfusion, activity intolerance, decreased cardiac output, and anxiety. Obviously, that would be low on your priority list. Unfortunately, heart failure can lead to cardiac arrest. Once a person is recognized to need CPR, emergency response needs to be initiated. Exceptions are near drownings, overdoses, or respiratory arrest. What you need to do is recognize the need, and hopefully you recall this from your CPR classes. And remember, what's important is circulation, airway, breathing, and defibrillation. And if you want more information about that, you can check the link. So if you have any questions, please please feel free to check with me. But like I said, this was a quick overview, and make sure you know your left from right sided heart failure, and best of luck to you. We'll see you later.